Okay, so this is chapter 32A, part A. We have split this chapter into two parts, and this slide is going to review disease processes of the cardiac system, respiratory, GI, urinary, and then a brief overview of endocrine. So moving into this slide, we're going to discuss, I would like you, before we get into cardiac anomalies, I would like you to review these videos. This first one here is fetal circulation, remembering that how the baby pumps blood and oxygen through its body is very different than a non-fetal heart. So once the baby is out of utero, that second video is to review what cardiac circulation looks like, how blood moves through each chamber of the heart when it's oxygenated, and then how it perfuses to the body. So it's important that you understand these two baselines, so please review these videos just as we go through the next couple slides. It might help you understand where the issues are at play here. Okay, so congenital heart disease. Why does it happen to kids? So there are a lot of factors at play here, but several environmental factors can include maternal alcohol use, if the mother has diabetes, if there's an advanced maternal age, potential drug use while the mother is pregnant, and then genetic issues would be, do the siblings, have they had congenital heart disease? What about the parents? Does it seem to run in the family? And then are there any chromosome anomalies? Multiple pediatric chromosomal anomalies are a dual diagnosis with cardiac issues. So, for example, Down syndrome, a lot of them end up having serious congenital heart disease defects in conjunction with the chromosomal anomaly. So keep that in mind. As far as the types of different cardiac disease processes, they're kind of bucketed into 4 different classifications. Previously to this, they used to be left or right-sided cardiac issues, but that's really difficult to bucket them that way. So now they've kind of started to change the way that they classify them into 4 different types. So it's important to understand the following couple slides, whether they fall under 1 to 4 of these different defects. Okay, so there's 4 different types again: increased pulmonary flow, decreased pulmonary flow, obstruction of systemic blood flow, and then mixed blood flow. Okay, so to review, increased pulmonary flow, what does that mean? This is a defect that causes the blood flow abnormally from left side of the heart to the right side. It increases the volume of blood being sent to the lungs. So this often leads to pulmonary hypertension, congestive heart failure, and then excessive workload on the heart. Decreased pulmonary blood flow. This is a defect that causes blood flow to the lungs to be restricted, which essentially reduces the amount of oxygen entering the bloodstream. The body receives poorly oxygenated blood, which leads to cyanosis and hypoxia. Obstruction of systemic blood flow. This is a type where there is a blockage or narrowing that impedes blood flow from the left side of the heart to the body. This causes high pressure in the left side of the heart and leads to insufficient blood supply to major organs and tissues, results in a low blood pressure in the lower portion of the body, and also poor perfusion, of course. And then a mixed defect. This is when oxygenated and deoxygenated blood mix within the heart or the great vessels, leading to circulation of the body that has less oxygen than normal. This results in cyanosis as the body receives partially oxygenated blood. Okay, so how do babies present when they have congestive heart disease? Obviously, one of the more obvious signs is cyanosis, so their skin color. If the baby is blue, specifically centrally cyanotic, so around the lips, in the face, that's concerning. With further investigation, cardiomegaly can be found if they do an echo or an MRI or even a cardiac cath. They're going to notice changes in the enlargement of the heart. They can be heard with different heart tones, pericardial rubs, murmurs, and different additional heart tones other than S1 and S2. There can be noticeable discrepancies between the apical and the radial pulse. And then it's really important to understand that pediatric patients or infants are specifically going to show an increased work of breathing. in conjunction with cardiac diseases. So the lungs and the respiratory status is trying to compensate for the decrease of perfusion or the decrease of oxygenated blood in the system, so it will work harder to breathe and move oxygen through the lungs, which results in tachypnea or dyspnea. And then as the baby weakens and or gets tired from working that hard, it'll be noticeable in grunting, possible crackles and wheezes, and that shows itself specifically in babies that are having difficulty eating. So if a baby is, like, the work of eating is really intense and they seem to be struggling to eat and breathe at the same time, that usually is one of the first indications that there's potentially a cardiac disease going on. Okay, so like I reviewed before, there's 4 different buckets that we are going to place these following disease processes in, or cardiac issues in. So the defects as follows are increased pulmonary flow. This is the most common one. So of the following slides, patent ductus arteriosus falls under this category. Atrial and ventricular septal defects also increase the workload on the lungs. Defects with decreased pulmonary flow involves tetralogy of flow. And then mixed defects, this is when the oxygen is mixed, deoxygenated and oxygenated blood mixed. This is transposition of the great vessels. And then obstruction to systemic blood flow, we're going to talk about coarctation of the aorta. Okay, so the first one here, a patent ductus arteriosus. Remember that this ductus arteriosus is a fetal artery that connects the pulmonary artery to the aorta. So while in utero, this is on purpose, okay? But it should close when the baby is born. So failure of the ductus arteriosus to close within the first few weeks of life allows blood to shunt from the high pressure aorta to the low pressure of the pulmonary artery, which is unoxygenated blood. This is a mixture of the blood as well, but ultimately what it does to the heart is it increases the pulmonary flow. This ranges in a wide range of symptoms, but mostly heart failure is the most prevalent, okay? It clinically manifests with heart failure, poor eating, poor growth, excessive fatigue. Sometimes there may be an audible machine-like murmur. They can even present with bounding pulses. And then how do we fix this one? This is a surgical closure, typically. Okay, and what is an atrial septal defect? So this one is a little more simple to understand. It is an abnormal opening in the arterial septum, so that the wall between the two atria. This allows blood flow to go from the higher pressure side, the left side, to the lower pressure, which is the right side. Symptoms range from asymptomatic to heart failure. So these, depending on the size of the hole in that wall there, is going to depend on the symptom level, okay? So when it is bad enough, manifestations can be heart failure, frequent respiratory infections, increased work of breathing or issues with their breathing. Management, depending on how severe it is, if it's minor, they're just going to monitor it. In more severe cases, this is going to be open heart surgery with bypass to suture or patch that heart hole there. Okay, ventricular septal defect. So this one here is an abnormal opening in the septum, or the wall between the two ventricles. So it results in the flow of blood from the higher pressure side being the left, to go into the right side of the ventricle. Sometimes, again, this is varying symptoms depending on the seriousness of the size. It can be pinhole or it can be a complete lack of septum. So it just depends on the severity of how large that hole is that will present with symptoms for the child. 50% of them can close on their own. The other requires open heart surgery. So how does it manifest itself in kids? Again, heart failure symptoms, a harsh systolic murmur or thrill. And then it's important to understand that this one falls under increased pulmonary flow as well. Okay, so tetralogy of flow. This one is technically a combination of 4 defects: pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. So these symptoms, again, vary in seriousness, but almost always result in severe cyanosis and hypoxia. It's important to understand that this one falls under decreased pulmonary flow. Patients typically present with cyanosis at birth with blue spills, systolic ejection murmur, a noticeable secondary heart tone sound, and this one is always repaired by surgery. Okay, this video here, or this slide here, shows kind of like a feel-good video of Jimmy Fallon and his experience with his child being diagnosed with tetralogy of Fallot. It's a good video. It just talks about his experience as a parent, and highlights of it that I reviewed in class typically are that you want to be on the side of medicine that when you hear something, you report it. So it is a story of his child, how the nurses and the care team worked together to create positive outcomes, and that's always the side of medicine we want to be on. So the biggest takeaway of this is that from this class, I'm not expecting you to be an expert in cardiac anomalies, but I am expecting you to be able to report and or share your concerns up the chain of command. So if you feel like the baby is struggling, or there's an increased work of breathing, or something doesn't feel or sound quite right, then by all means, it's within your scope, and I empower you to report it, because it will make a difference almost always. And then the second part of this slide is an application you can download on your phone. It works for either Android or iPhone users. It is a great visual for cardiac anomalies. That is a 3D picture that shows you what the heart looks like when it has the disease process or the issue, and then what it looks like after it's repaired. So it's a great learning tool if you're a visual learner. Okay, the last one here is transposition of the great vessels, or not last one, there's two more. Transposition of the great vessels. This is when the pulmonary artery arises from the left ventricle and the aorta arises from the right ventricle. So they're really switched. This causes venous blood return to the right side of the heart to exit through the aorta before it goes to the lungs to be oxygenated. Symptoms range again, but from basic cyanosis to complete heart failure. A lot of times on X-ray, they're going to see cardiomegaly. And a lot of times this is in dual diagnosis or in the presence of an atrial septal defect or a ventricular septal defect. Almost always, this one is going to require surgical repair to switch the major vessels. Okay, now correctation of the aorta. That's a fancy word to mean narrowing. So the narrowing of the lumen of the aorta, as seen on the top of this diagram in the circle, it's where it gets really, really small and then back to the size that it should be. So this narrowing results in an increased pressure on the left side of it, resulting in increased pressure proximal to the defect. So the body or the lower extremities. What does this mean exactly? The blood pressure in the arms can be as high as 20 milligrams of mercury higher than the legs. Bounding pulses in the lower extremities. If it's not caught immediately, it can result in signs of heart failure, like cramping on exertion and epistaxis. Almost always this is going to require surgical correction with an end-to-end anastomosis, where they just take out the narrowing. Sometimes can even require grafting, depending on how much of the vessel is experiencing a narrowing. If they're not able to do an anastomosis, they would need to create a graft. Okay, we're going to move into blood disorders or blood diseases that children may experience. So the first one here is iron deficiency anemia. Not a rocket science concept necessarily, but it can be a decrease in red blood cell volume and a decrease in hemoglobin, or both. Essentially, it's reducing the oxygen carrying capacity of the blood. So both of those things are going to be what keep oxygen inside the bloodstream or carry it around the body. So what are the clinical manifestations of this? The hemoglobin is below 10. So they present themselves with fatigue, anorexia, skin pallor, they're going to be pale, they might even have pale mucous membranes, increased heart rate as the body is trying to move oxygenated blood around. The heart is going to pump faster to get the little red blood cells or hemoglobin in the body to move oxygen effectively. In severe cases, there may also be systolic murmurs. In kids, it'll often present itself with weakness or decrease in activity. So how do we combat this? Typically, WIC provides iron-fortified formulas. Breast milk have tons of iron in them now. We've identified it as an issue for pediatric patients, so therefore they have really increased the amount of iron-enriched foods available. It really peaks itself between 6 and 24 months. It's because babies at that point are not only relying on formulas and they're eating solids, so if we're not giving them iron-rich options for foods, they can be more prone to becoming anemic during that period. So medical management, again, is iron replacement therapy. So whether they're getting it in foods, enriched foods, or maybe they're needing nutritional counseling, maybe it's severe enough that the family needs review of what kinds of food would be high in iron. And then it's also important to understand that maybe there's an underlying condition going on here. Maybe it's not just that they are anemic. Maybe there's a bleeding disorder, a GI issue, or a malabsorption problem going on here. Let's see. So labs that you would be considering. When you think of anemia, what types of labs are you going to be looking at? So CBC, ferritin, reticulite count, and serum iron. All of those things are really going to be looked at in blood panels when trying to determine the severity of anemia. So let's think through some foods that would be great for kids to eat. So when we're talking about dietary counseling, this is what we're talking about. So it's not only in red meat, okay? So that's like one of the first one that comes to mind, but any type of bean is really great for kids. Dark leafy greens, which can be tricky sometimes to get pediatric patients to eat. Nuts and seeds, dried fruits, trail mix is a good option. And then just in general, it's important to understand that vitamin C helps absorption of vitamin D, and calcium slows the absorption. So keep that in mind when you're talking about different iron foods. Vitamin D and iron go great together, but if they're intaking a ton of vitamin C, then it's going to decrease that absorption capability. Okay, moving into sickle cell anemia. So what is this? This is a genetic disorder caused by an abnormal formation of the hemoglobin within the erythrocyte. So essentially what happens here is the shape of the red blood cell is no longer circular, it's almost C-shaped, so it has a bend in it. This causes it to become elongated in shape, and it causes vascular congestion, essentially. So how do children manifest with this? So as the red blood cells are have difficulty traveling through capillary blood systems, they present with irritability, fatigue, joint pain. It's most common in African American populations in 1 in 500 kids. Why does it happen? We really don't know. It's an intermittent phenomenon, as they say. Precipitating factors, things that make it worse, actually for kids are infections, fevers, dehydration, COVID, stress. Any child that has sickle cell anemia, those things can make it worse. So again, this is when the red blood cell is abnormal in shape and it can't make it through different systems in the vascular systems in the body. And depending on the severity, it can cause a sickle cell crisis. How do we manage it? Medical management is typically palliative, so symptom management essentially. So that is analgesics, ibuprofen, Tylenol, increasing hydration, potentially oxygen, and transfusion of hydration or packed red blood cells. Interventions as a nurse are going to be to maintain hydration, to administer pain meds as possible, and then promoting comfort measures, so distraction, play therapy, warm packs can help, warm baths, local heat to the joints or extremities that are hurting. Really, they're just going to be symptom management, so they're going to be inpatient for this and then getting hydration or pain meds and or packed red blood cells if necessary. Okay, moving into aplastic anemia. So this is due to a failure of the cell generating capacity of the bone marrow. So this is really rare, but it is essentially an issue with bone marrow's ability to make correct cells. Okay, it can be an issue of making red blood cells, white blood cells, and or platelets. So all formed elements of the blood are defective, underdeveloped, or absent, resulting in a severe anemia, thrombocytopenia, bleeding, or leukopenia. It may be caused by a neoplastic disease or a cancer of the bone marrow, but more commonly by destruction of the bone marrow through toxic chemicals, ionizing radiation, or even some antibiotics and treatment. So what does that mean? We might be causing it due to some of the environmental agents children can be exposed to, or potentially, say, a child is treated for a type of cancer. Sometimes when we treat cancer, we cause harm to previously well-functioning systems like the bone marrow. So it can be a secondary issue to chemo treatments for some patients. This is going to require almost always bone marrow transplant. That's the management or treatment for this, and that is a large deal for pediatric patients. It is a long process to go through. It's typically painful, and then there's a lot of management afterwards with any type of transplant with pediatric patients. Okay, so moving on to hemophilia. This is a serious lifelong bleeding disorder, which is an disorder of the X-linked recessive gene. Okay, so it's a defect of the X chromosome. Men carry only one X, and females carry two. So in general, women are more carriers and males are more affected. What is this essentially? It's a deficiency in factor VIII. The blood cannot clot, essentially. So how does it manifest? It presents with bleeding, oral bleeding or bruising, persistent bleeding from minor lesions, so like a little scratch is going to not be able to clot. And then in severe cases, hemoarthrosis, which is bleeding in the joint spaces, which was what you're seeing in this photo here. If frequent, it can lead to bone deformities, as obviously large bone joints are not meant to hold large volumes of blood. So if this goes untreated for a long time, it can cause bone deformities. How do we treat this? So we treat this by pressure cold packs if there's an isolated minor bleed externally. Ultimately, though, replacement of factor VIII is going to be needed to control more serious bleeding. The book discusses RICE, which is rest, ice, compression, and elevation. What do we need to know in general as nurses here at patient? Parents are taught to protect children without being overprotective. So essentially, when your child has a bleeding disorder, you're going to want to teach parents that it's not just a little bit of a bloody nose, that they don't have the ability to bleed. So we are going to need to stop that with medication. Their body doesn't have the functionality to clot on its own. So small bleeds can be emergencies, and or what is more obvious is external bleeds like a cut or a scrape or an injury. But if a child hits their head and they have a bleeding disorder, that they can have intracranial bleeding, which would require medical attention, emergent medical attention. So idiopathic thrombocytopenic purpura, also known as ITP, this is essentially when there's a marked decrease of the amount of circulating platelets inside the bloodstream, resulting in bleeding beneath the skin, which is what that photo is showing there. So essentially the immune system attacks itself and mistakenly attacks its own platelets. This is typically an autoimmune disease process. We don't really know exactly why it happens. They also correlate its potential with being virally induced, which is interesting. This commonly affects ages 2 to 10. And how does it manifest itself? Other than bleeding, the child appears well. There's no other disease process that's obvious going on here. There's no fever or such. They seem to be doing well, other than they're having issues with bleeding. So that might present itself with a pinpoint petechial rash or ecchymosis. It can, in severe cases, lead to intracranial hemorrhage, but often is seen before that with bleeding in the gums and the lips. Hematuria, so urinating of blood, vomiting of blood, or increased menses. Those would all be signs that this function could be going on. What do we need to know as nurses? So nursing interventions here is to prevent bleeding or prevent bruising and to control bleeding. Essentially, we're going to be teaching families to protect their child by ultimately restricting the type of activities that they do. We're going to need to prevent them from injury, right? So children with ITP should be avoiding contact sports, unfortunately, which is difficult for kids that get it at this age. When it affects 2 to 10-year-olds, that's difficult to tell them to be careful. And then also with that, we should be teaching families not to be using salicylate drugs like Advil, right? Because aspirin and Advil can cause increased bleeding time. So how do we medically manage this? This is almost always going to be transfusions of packed red blood cells. Because it's an autoimmune disease process, often they may be given IVIG or anti-D antibiotic therapies and potentially even removing their spleen. Okay, so another unfortunately common neoplastic disorder or blood disorder that children can experience is leukemia. This is the most common form of cancer in children. It affects more males than females, and its peak incidence is between 2 to 6 years old. That being said, it has a high survival rate of about 80%. So what exactly is leukemia or ALL? So it's acute lymphoblastic leukemia. It's an uncontrollable proliferation of blast cells meaning immature cells. These accumulate in the bone marrow, causing crowding and depression of other healthy cells. So kids typically present with decreased pallor, increased fatigue, leukopenia with fever and infection, thrombocytopenia with bleeding and petechiae, bone pain, limping, joint pain, and swelling. Okay, so medical management for leukemia, depending on the severity, when they're diagnosed, the stage, all treatments are highly individualized for each child. Specifically, this involves chemotherapy, however. There are some new therapies out there called CAR T cell therapy or T cell therapy. I'd encourage you to look it up online or ChatGPT that treatment process. It's not in our textbook, but it is a specific cancer treatment for leukemia, again called CAR T cell therapy. What do we need to know for pediatric patients? How do we discuss teaching with their families, and how do we intervene as nurses? So this is a super stressful situation for parents. Pediatric oncology is a whole nother animal. Their parents are really worried about the prognosis for their child, and then being able to manage the treatment plans for this is really an intense rigor. So in general, we treat with targeted therapies, bone marrow transplants, and supportive therapies and chemotherapies. These kids are really at a specific increased risk of infection. So as we obliterate their immune systems to try to target and stop the body from proliferating incorrect cells, we do interrupt natural immunity. So they're at an increased risk for infection. So we want to prevent expected side effects, which are typically secondary infections. We want to Observed for late effects of treatment, which typically are nausea, vomiting, and dehydration, and then immune status. So all of that being said, kids with childhood cancer, we want to try to help them thrive and live as normal of life as possible, as difficult as that can be. And then, of course, we're assisting the families and the kids, depending on their age, with the emotional aspects of having a childhood cancer. What else? Less than 2 respond to treatment better. So the younger the child is, the more favorable the outcomes are. And then girls have more favorable outcomes than boys. And Hispanics, for some reason, have a decreased cure rate. All right, moving on to Hodgkin's disease. So this is a cancer of the lymph system. It's kind of a sneaky snake in the fact that it's almost always painless and an extreme progressive of enlargement of the lymphatic tissue. It's believed to occur typically in one site and then spreads to nearby lymph tissue. It's more common in males and rare in children under 5. Typically affects teenagers between 15 and 9 years old. Treatment protocols for children follow the same protocols as adults. So this is typically bone marrow transplant and potentially, or they're going to remove lymph tissue that's affected, possibly do chemo and localized radiation. So that would be what we would be doing for adults. So because of their age between 15 and 19, we do treat them like adults, how we would treat lymphoma or Hodgkin's lymphoma in adult patients. All right, moving into immune disorders and immune function. We've already discussed HIV and AIDS in MedSearch, but we're going to talk about this specific to pediatric patients. So what is HIV? This is human immunodeficiency virus, and AIDS is acquired immunodeficiency syndrome. It's important to understand that AIDS is a progression of HIV. Okay, AIDS is a chronic and usually fatal disease due to the acquired dysfunction of the immune system, which is caused by the human immunodeficiency virus. Okay. HIV has been found in blood and in varying amounts of body fluids such as semen, vaginal secretions, breast milk, tears, saliva, and urine. So what do we do to protect kids? We prevent mother-to-child transmission as much as possible. We decrease the mother's viral load when we know she's positive. They're going to do C-sections versus vaginal delivery potentially. And then we're going to discuss alternate routes of feeding versus breastfeeding for a mom that may be positive for HIV. Why do kids get HIV? Most commonly, it's through maternal child transmission. They get it from their mom. Unfortunately, other cases can be their bloodborne disease passing. So whether that's by another affected child or potentially through sexual abuse. Let's see. Again, it's important to understand AIDS is an advancement of HIV, an advanced stage of HIV. Treatment is typically to just slow the progression and by treating antivirals. We would check labs, specifically CD4 is testing T cells, which are the helper cells. They're a direct response to viral load. How do kids manifest if they have AIDS or HIV? Typically in weight loss, potentially a secondary meningitis, development and growth delays, failure to thrive, progressive neurological disease, frequent viral and bacterial infections, and typically they're at increased risk of fungal pneumonia. It's important to understand because this virus is attacking the immune system, we are trying to prevent opportunistic infections, meaning that their immune systems are low, meaning they're at an increased risk for consistent infections. Treatment, again, is to slow the virus and to prevent other infections that they could technically die from, as simple as pneumonia or a fungal pneumonia because their immune system is so weakened. Box 32.2 on page 991 goes over some different medications and therapies. It's important to understand that there's no cure for HIV, just treatment, and that it is lifelong. Some other nursing interventions to keep into consideration would be monitoring their growth and development. Severe failure to thrive is common in these kids. And then, of course, we want to support their family. This is a lifelong treatment, and kids are subject to how their families manage medications and understand the disease process. They might need extra services, other social services like home health, nutritional services such as WIC, etc. One point to keep in mind is that it's important to understand and help the parents educate teenagers in regards to avoiding casual sex and using condoms, because of course this is how, teenagers in general are very poor at having educated and or informed sexual intercourse, and so you add layers of sexually transmitted disease and kids are really not going to talk about it. It doesn't necessarily mean that they're not going to still have sex. They just are going to potentially be spreading it. So it's imperative that parents understand the importance of discussing safe sex and also empowering kids to be aware of what this means to pass something like this on. Okay. Another immune system disorder is JRA, or juvenile rheumatoid arthritis. This affects girls twice as much as it does boys. What is it? It's a chronic inflammatory or autoimmune disease process that affects the connective tissue. It erodes, destructs, and breaks down the cartilage in the joints. It is a systemically manifested disease process. Typically, and oddly, it presents itself with afternoon spikes in temperature, macular rash on the trunk and extremities, and almost always involves joint pain. How do we check for this, or how do we diagnose it? It's going to be off of a history and a series of symptoms. We're going to look at their history, and different labs that we're going to look for are their ESR, CRP, and CBC. So how do we treat this? These are always with non-steroidal anti-inflammatory drugs first. Then they're going to layer in anti-remetic drugs, cytotoxic drugs, and steroids. So page 992, there's a column that goes through the different medications, but most of the common ones are methotrexate, rituximab, Humira, Orencia. Some of those may or may not sound familiar. It's important to know that this is, again, is almost always lifelong, and that early recognition is going to prevent permanent joint damage. And then these kiddos too are going to very much benefit from symptom treatment, including physical therapy, to increase and improve joint mobility as those joints are under stress. Okay, we're moving into respiratory disease processes. So what is respiratory distress syndrome? This is caused almost always by a deficiency of surfactant. It's a severe lung disorder affecting preterm and low birth weight infants. Without surfactant, the infant is unable to keep the lungs inflated, and the alveoli collapse at the end of expiration, resulting in hypoxia, atelectasis, and respiratory acidosis. It is more common in boys and in infants that happen via C-section. Let's see, so how do they manifest themselves? This is after they're born, and if they're having respiratory distress syndrome or RDS, it almost always is going to involve nasal flaring, expiratory grunting, intercostal and subcostal substernal retraction, so accessory muscle usage. Their color is going to be poor, dusky, cyanotic. They're going to have increased work of breathing, low body temperature, and if untreated, can die within hours of symptom onset. The video here is a video of a baby in distress that shows the physical symptoms you might see when the baby is going into distress syndrome. Some of the predisposing factors for babies outside of being low birth weight or C-section can be maternal diabetes, asphyxia, maternal hemorrhage, and shock. All of those might increase the risk of the baby having this syndrome. Okay, Medical management. So what happens when a baby comes out and they're experiencing RDS? So all of these symptoms are entirely supportive. We're going to maintain their thermal environment. That's why they go into incubators to manage their temperature. We're going to maintain adequate oxygenation, so supplemental O2. And then we're going to correct respiratory and metabolic acidosis. They may even probably likely need TPN because the work of breathing is too intense. And then we're going to administer surfactant. TPN is, like I said, probably going to be ordered because the risk of normal breathing and eating, their risk for aspiration is too high. So we give them surfactant when they're born, and then monitor their temperature and give oxygen and supportive airway treatments as necessary. We're going to assess them consistently, observing for their respiratory status. How are they responding? Is their O2 coming up? Is the work of breathing not too intense that it requires intubation? Again, with frequent respiratory assessments, we're going to help suction them as needed because secretions are just going to get in the way of breathing effectively. And then we're going to position the baby on their side with head support because, again, they're very fragile and little at this point. And then if when babies are in incubators like this, they're going to need consistent skin checks for pressure points. So on top of respiratory assessments, we're going to be checking their skin frequently. And then we want to support the parents emotionally. So this is very stressful for parents when their kids are struggling to breathe and they're put in incubators and or needing supplemental oxygen. Parents feel very helpless. So we're going to want to allow them to participate in the care. So bronchopulmonary dysplasia, this is another issue secondary to respiratory distress typically. This is almost always a complication or can be a complication with prolonged mechanical ventilation. So with an increase of impairment of oxygen diffusion, the alveoli collapse due to edema and inflammation. How does the baby manifest with this? Respiratory distress, upper respiratory infections. And how do we prevent it? Precautions are taken to prevent respiratory distress syndrome, which would keep them from this being a secondary issue. And as we reduce ventilation and oxygen requirements, we're preventing this complication. This is meticulous management of ventilation, which is why NICUs are so imperative for kids that are requiring this type of care. Let's see. Prognosis for this, if they suffer from bronchopulmonary dysplasia, the mortality rate is high or higher. They're at a greater risk for this disease process if they have had acute respiratory distress, if they've been mechanically ventilated, or if they've aspirated meconium during delivery. So again, with increased levels of O2, positive pressure and ventilation plus intubation causes chronic lung issues, chronic lung changes. How do we diagnose it? It's nothing super specific. Sometimes they'll do pulmonary function tests, but most of it is based on symptom severity. How are they able to move oxygen? And when they try to remove mechanical ventilation, how do they tolerate it? So nursing interventions for this on the next slide here. So nursing interventions. So we're going to plan rest periods to decrease respiratory effort and conserve energy. We're going to do small, frequent feedings. We're going to help the parents be comfortable with holding their kids with all of the extra equipment attached to their child. We're going to teach parents how to do CPR and how to manage other emergencies. So if these patients end up leaving with trachs, they'll have extensive care in how to manage that. And then we're going to teach parents how to reduce the risk of respiratory infections because these kiddos are at an increased risk of such. So again, just to review, with mechanical ventilation, it's imperative that that they get enough support, but not to overinflate, which would cause scarring, and which causes that chronic lung change, which is decreasing the ability to transfer oxygen. What is pneumonia? So this should be review, of course. This is an acute inflammation of the pulmonary parenchyma. That's the tissues around the airways. This is the tissue responsible for O2 exchange, which is the alveoli, the ducts, the capillaries, and the bronchioles. So all the small airways and alveoli are inflamed. Why does it happen? Typically bacterial, can be viral pneumonia or fungal, or can be caused by foreign body aspiration. How does it manifest itself? Again, this should be reviewed, but this is cough, wheeze, crackles, increased secretions, respiratory distress, chest pain if the child is old enough, abdominal pain, headache, anorexia, failure to thrive, irritability, lethargy, nasal discharge. And this is always most common during respiratory season or winter months. Viral is more common than bacterial, unfortunately, and RSV is one of the biggest percentages of infections causing pneumonia in children and infants. How do we manage this? If it's bacterial, it's with antibiotics. We're going to give bronchodilators and antipyretics, oxygen if necessary, chest physiotherapy, so chest cuffing, suctioning or secretion management, and then fluid administration, because kids, when they have respiratory illness and fatigue, they're at an increased risk for dehydration. The goal is to improve oxygenation and prevent dehydration. Okay, moving into SIDS. This should be review from our MC course, but again, what is SIDS? It's a sudden, unexpected death of a healthy baby under the age of 1 whose post-mortem examination fails to establish a specific cause of death. It is the leading cause of death among infants ages 1 to 12 months. 2 in 1,000 die from SIDS, and for some reason males have a higher incidence. Death typically occurs during their sleep, and there is no audible outcry or signs of distress, which is why they call it sudden, because there's no obvious sign that they're struggling to breathe. How do we manage it? This is directed towards assisting the family. So if there is a baby that dies, management is, of course, emotional support. On page 996, there's a box that you can read more about this. Nursing interventions. Medical personnel should be comfortable with discussing this with families, which is not easy. Trying to remain non-judgmental, asking few questions, and providing the family with support. Parents have an immense sense of guilt if their child dies from SIDS. They're trying to determine what could they have done differently. So by asking a lot of questions, they may feel attacked. A lot of these families are going to very much need therapy. The nurse should stay with the parents, listening to them, supporting them, and finding referrals for mental health as necessary. So prevention is the #1 nursing intervention that we can try to help families with. The American Academy of Pediatrics recommends that back is best, so laying on their back, as pictured here. So again, we talked about some of those things in MC, but increased ventilation of rooms, no stuffed animals in the bed, swaddles, or not having big fluffy bedding in a crib is going to be beneficial. And then if there's bumpers or side bumpers, that they're mesh and breathable, not padded rails on the crib that a baby could suffocate. Okay. Another common respiratory disease process here is acute pharyngitis. So there's pharyngitis and tonsillitis. So the first couple slides here, we're going to talk about pharyngitis, which is essentially acute sore throat, okay? This is inflammation of the back of the throat. It can be in combination with low-grade fevers, fatigue, anorexia, redness in the back of the throat, and throat hoarseness, typically in conjunction with headaches, cough. Again, that voice hoarseness is almost always present in little kids. And unfortunately, this is typically viral, which is super irritating for parents because we want it to be strep throat, right? We want it to be caused by a strep bacteria so that we can get antibiotics. So sometimes it can be, but if they're testing positive with strep cultures, it would be that it's viral. So how do we know the difference between it being viral and bacterial? Almost always do bacterial pharyngitis come with white pus pockets in the back of the throat, nausea and vomiting, and abdominal pain in conjunction with the rest of those symptoms typically indicate that it's from a group A strep. Management for viral pharyngitis is treated treating the symptoms with lozenges, gargles, Tylenol, ibuprofen as needed. Again, if it's bacterial, that's a 10-day course of antibiotics. Typically, the penicillin or amoxicillin is the drug of choice. Nursing interventions, again, saline, gargles, lozenges, warm compresses to the neck, Tylenol and ibuprofen, soft, easy, bland foods, cool liquids, popsicles, things that are going to help with the sore throat that are easy to go down. So like pharyngitis is tonsillitis. This is very similar in its presentation. It's just lower down in the airway or down farther than in the back of the throat. It's the pharyngeal cavity. Farther down into it, I should say. This usually occurs as a result of pharyngitis and then causes tonsillitis, okay? Can be viral or bacterial. Clinical manifestations are the same. How we manage it, same thing. Comfort measures, if it's bacterial, it will include penicillin or an antibiotic. If it's reoccurring frequently, tonsillectomy is recommended, especially if it is so swollen that it affects their work of breathing or eating, that is. So tonsils can be removed if they have reoccurring infections. Okay, so specifically related nursing interventions to preoperative and postoperative tonsillectomies. If they're having their tonsils removed by ENT, we're going to provide psychological preparation, so anticipatory guidance for kids, helping them understand that what this is going to look like is going into surgery, and assessing signs of an active infection. They typically don't want the child to have an active infection before removal. And then any loose teeth, because that would cause an issue with intubation, of course. Postoperatively, it's important to understand that hemorrhage is very possible between 5 to 10 days after having tonsils removed. So we're going to monitor for frequently for excessive bleeding, which in kids is going to be frequent swallowing. So if they're consistently swallowing after this type of procedure, and you should be concerned that they're swallowing blood. And then we're going to give pain management as ordered. It's important to push fluids, nothing acidic, red or chocolate drinks, because they're going to look like blood if they vomit. So we don't want to possibly confuse something they're eating with blood. Okay, moving into croup. So what is croup? It's typically an acute viral disease that is indicated by a barking cough. So it's usually an upper respiratory infection. It's got a very distinct sound. The video clip here at the bottom is an example of what you might hear when you hear a child with croup. It's important to understand, though, that a complication of croup can be acute epiglottitis, and this is severe, potentially life-threatening bacterial infection of the epiglottis, which is the hangy-bally thing in the back of your throat. Okay, so if this is suddenly inflamed, it can actually prevent intubations, even requiring tracheostomy. So if that epiglottis gets so large and so swollen that it blocks an airway, it can block it so much that you're not actually able to intubate them in an emergency, or that they would have to create a tracheostomy, which is what this is indicating can lead to total airway obstruction. In that case, they would do an emergent tracheostomy. So how does it present itself with that barking, hoarse cough? Typically, you're going to hear an inspiratory stridor. So that's going to go, ooh, ooh. So the noise is going to be on the inhale, okay? Tachypnea, or an increased work of breathing, external muscle usage, which would be nasal flaring, substernal retractions, and again, that barking cough. Medical management for this is going to be symptoms. So high cool mist, humidity, oxygenation by mist, epinephrine by aerosol. If the airway is really restricted, they're going to do epinephrine nebulizer. nothing by mouth during this acute phase. So the baby or the child is going to be at an increased risk for dehydration. So they're going to be providing frequent rest periods with eating or moving into oral IV hydration if necessary. And then if it's severe enough, artificial airways as needed. So what do we need to know about croup? So responding quickly in a calm manner. So if we're worried about restricted airways or a closing of the airway or a complication of acute epiglottitis, we're going to want to be calm but move quick. Assure the parents that to remain calm. Children always feed off of their parents' fear. So sitting them up in a Fowler's position, monitoring vital signs and respiratory status. They may be monitoring cardiac status based on stress that the respiratory system puts on the heart, and then again providing rest periods. Okay, moving into bronchitis or tracheobronchitis. So what is this? This is an inflammation of the large airways, the trachea specifically, and the bronchi, usually following an upper respiratory infection. Its most common causes are rhinovirus, parainfluenza, adenovirus, and RSV. Clinical manifestations for this are always a cough. They may or may not have a fever, and then after 2 to 3 days, the cough worsens, specifically at night. Medical management is going to be symptom management, so that's going to be cough drops, throat lozenges, cough preparations, Tylenol, mucus suppression, Tylenol and ibuprofen if they're having a fever. And then teaching is going to look like using cool mist humidifiers in the child's room when they're sleeping to help liquefy secretions, and always encouraging fluids. This unfortunately is a cough that can last up to 10 days or even over 10 days, typically secondary to infection, which may cause antibiotics. So if a child has these types of these symptoms over 10 days, it would be merited that they're seen for need for antibiotic therapy. Okay, moving on to pulmonary tuberculosis. So the primary source in children is unfortunate exposure to a caretaking adult who was positive for tuberculosis. So what is it? It's a chronic bacterial lung infection caused by the Bacillus Mycobacterium tuberculosis. So that's the type of bacteria that causes this. Clinical manifestations are usually none, unfortunately, until the disease has significantly progressed. So this is dangerous in kids. There's subtle onset of symptoms, typically cough, fever, weight loss, night sweats, failure to thrive, fatigue, chest pain. All of those, again, may not show up right away. So patient teaching is going to be instructing the parents regarding the importance of giving medications for treatment. If a child is diagnosed with TB, treatment can be 12 months long. Children during this time are immunosuppressed, which can be complicating the risk for secondary infections. So there's more spread when okay, what am I saying? So because the symptoms are subtle, it can unfortunately be not noticed until there's more spread, or when that it's spread to like tuberculosis, meningitis, or a widespread of that bacteria into the lymph tissue. Sometimes it can cause a serious spread before it's noted. And again, it is a long treatment, and then decreasing the exposure to adults is going to be the number one. Actively infected adults is going to be our best way to prevent kids from getting this. Okay, what is cystic fibrosis? So this is an inherited disorder of the exocrine glands characterized by excessive thick mucus that obstructs both the lungs and the GI tract. So it's commonly thought of as only a respiratory disorder. We classify it in here so that you can remember it, but it is important to understand that it affects all mucus in the body, okay? So this is a genetic disorder, makes the mucus in the body, in the lungs, and the GI tract thicker. So how does it clinically manifest itself? This can be in greasy or thicker stools. The consistency is different because there's an issue with the absorption of fats in the gut. Growth failures, protruding abdomen, thin and wasted extremities because of their malabsorption of fat, and chronic coughing, wheezing, sputum production, and shallow breathing. Frequent lung infections can be common. Again, some of these symptoms are present because of the malabsorption of fats due to the decrease of their pancreas working effectively, essentially. Okay, so CF is a multi-organ disease. However, death is typically pulmonary failure. So medical management of this to prevent pulmonary failure is going to be chest physiotherapy or CPT and postural drainage. So what you're seeing in this photo is an example of postural drainage, and then that chest physiotherapy are those vests that kids put on that shake them, essentially doing forced percussion of the lungs, which is causing the thick secretion to break up in the lungs so that they can be removed via coughing or cough assist devices, which essentially are suction where it pulls the air out of the lung, essentially a forced cough that helps with removing or expectorating secretions. Okay, and antibiotics may be necessary because of the thickened secretions in the lungs. They are at an increased risk for respiratory infections. So there again, CF is abnormally thick secretions. They collect in the airways and in the organ ducts. How do we diagnose it? Typically with genetic and blood tests. They're going to do pulmonary function tests to determine the lung status. These kids often have frequent hospitalizations, so nursing interventions are going to focus primarily on improving pulmonary function and facilitating in lung clearing, managing respiratory infections, and then promoting normal growth and development as we can. So airway clearance, and then another common treatment is inhaled antibiotics or tobramycin. Okay, let's see. So one other thing is with this chronic disease process, both affecting the GI system and their lungs, this really does impede normal growth development. So there are a lot of support groups for CF patients and their families, and a lot of the times they're going to need a multidisciplinary care team like PT, nutrition. They may even have G tubes for severe nutrient deficiencies, and as the body is working hard and the lung, all body systems are affected, they really are at an increased need of caloric intake. So even more so because more reason that they're going to need G tubes for nutrient deficiencies. Okay, moving into bronchial asthma. So what is asthma? It's a reversible obstructive respiratory disorder, a chronic inflammatory disorder of the airway. It manifests itself in a tightness in the chest, audible expiratory wheeze. Okay, so that's when they go, ooh, and there's a wheeze when they breathe out. Shortness of breath, tachypnea, dyspnea, restlessness, anxiety is very common with this as the work of breathing is so intense. The cyanosis and hypoxia causes anxiety. This cough progresses from dry productive. From dry to productive, and then a lot of times there's fatigue and sweating related to this work of breathing. 6.2 million children are affected with asthma, which is a lot. Okay, so in this photo here, you can see a comparison of the normal bronchial tubes and then those of during an asthma episode. So you can see how inflamed the airway is and restricted. Of course, air does not move as easily. So medical management for this is a combination of long-term control medications. There's an example on page 1002. And then there are quick relief medications. So you might have heard of fluticasone, budesonide, Pulmicort, Singulair, Pro-Air, albuterol, prednisone. There's quite a few medications out there, all inhaled, that are going to be ways that we treat this. So again, long-term and quick relief medication. So depending on the severity of asthma and how long a child has had this is going to really determine a combination of meds needed. And then what are we looking for as nurses? We're going to monitor their vital signs. Again, hydration is always important in pediatric patients. Fowler's position is helpful when you're having respiratory distress, providing rest periods, and then understanding triggers, okay? So avoiding triggers and teaching parents how to dose meds is imperative for kids' success with asthma. Okay, we're going to move into GI function. So the primary function of the GI tract is absorption and metabolism of nutrients, right? So any alteration of GI systems can affect all other symptoms, right? So starting at the top, facial malformation. This is a facial malformation, cleft lip and cleft palate. This occurs during embryonic development, and it is a failure of the medial, nasal, and maxillary processes to join. Essentially, the palate does not fuse. It can manifest itself with obvious facial malformations, feeding difficulties, speech difficulties, and reoccurring ear infections. This has been linked to several environmental factors, including maternal diet, alcohol consumption while the child is in utero, folic acid deficiency, and then smoking while pregnant. The next few slides show images of the severity here of the fuse. So this is a before and after. This is prior to repair and secondary to repair, which is actually pretty impressive. Plastic surgery has come a long way, and so kids can get away with having some serious facial deformities here of their lip and their nasal cavity, and you may actually not even notice. Here, this is obviously more severe. It's external, you can see, and then also on the right-hand side of this photo is a view of what the top of the roof of the mouth looks like. So the plate is not fused. So that white space there would go into the nasal cavity. So you can see why a child would have frequent reoccurring ear infections is because fluid that should be going down the GI tract is going up into the ears and then passing into the eustachian tube, up into the nasal cavity, and then into the ear canal or eustachian tube. So again, here's another before and after of repair, which is pretty impressive. This is obviously a more severe case. Again, before and after. This one is sneakier, right? So this one, the lip is intact, but the lack of fusion is really central into the back of the throat. This one I would say is probably more dangerous because you're not going to notice it potentially until a thorough physical examination after birth or potentially when they're presenting with feeding difficulties. So here's an older child that this was not repaired obviously until they were much older. Now, when you see the photo on the left, this is a great visual for why they would have difficulties with eating, absorption, swallowing, and requiring modification. Okay, so how do we manage this? This is always surgical closure. Typically in the first few months, if possible. Sometimes they may provide a prosthetic device that kind of mimics a palate, like a denture plate essentially. Not with teeth, of course, but it can be like a prosthetic that clips onto the top of the jaw to close the gap if surgery is not merited right away. So kids that have this disease process or this issue are going to, again, have multidisciplinary care teams, pediatric plastics, orthodontics, otolaryngologists, speech pathologists, audiologists, social workers. All of these people are going to help families make sure that babies are essentially able to take in proper nutrition and hydrate appropriately. So nursing interventions are going to include just that, ensuring adequate intake of food without aspirating, right, this can pose as a difficulty. Special feeding devices may be used, like an elongated nipple, and then frequent burping is necessary because the likelihood of them swallowing air more than a child with an intact palate is really common. And then we're going to assist parents with dealing with the diagnosis. Of course, these types of facial deformities are grossly upsetting to parents. And so showing them examples of before and after pictures, or just encouraging them that plastics and surgeries have come a long way. That initially this can be really upsetting, but that babies do have successful repairs all the time, and that their post-operative healing and or actual notice for scarring is decreased tremendously. Okay, so with pediatric patients, I think I've alluded to this quite a bit, but dehydration is not taken lightly with pediatric patients. So what is dehydration? This should be a review of concept, but we're going to hone in on what it means for kids. So this may be the result of a number of disease processes, right? Dehydration is usually a secondary issue to another type of infection or problem going on. But ultimately, it is a abnormal loss of fluid through the skin, respiratory, renal, or GI symptoms. It manifests with loss of skin turgor, dry mucous membranes, sunken eyes, lethargy, rapid weak pulse, low blood pressure, and rapid respiration. This is when the total intake is less than the output. Okay. On page 1005 and 1023, there are specific charts related to dehydration. Again, I think this isn't a repeated or you've probably already seen this in MedSearch, so we're going to go on here. How do we manage dehydration? Similar to diarrhea, we're going to increase fluids. We're going to increase fluids. Hopefully, if dehydration is secondary to like a GI bug, then that might be IV fluids. If dehydration is secondary to respiratory infections, that can be if they're on mechanical ventilation or such, then maybe it is a G-tube. Whatever it is, we're going to give fluids however is tolerated, whether that's via G-tube or IV fluids. Nursing interventions. How do we assess for dehydration? We're going to watch INOs, vital signs, body weight, skin color, temperature, turgor, cap refill. Are they showing signs of thirst? Infant assessment is going to include fontanelles. So what do you notice in this photo? What I'm noticing is a sunken fontanelle. This would indicate that their baby is dehydrated. This should really be flat and not noticeable. We don't want it to be bulging, but we also don't want it to be sunken. Okay. Labs that we monitor for dehydration include sodium, glucose, bicarb, BUN, those types. Moving into diarrhea and gastroenteritis. What are these? These again are common, should be reviewed for you, but these are a disturbance in the intestinal motility, characterized by an increased frequency, fluid content, and volume of stools. Diarrhea is one of the most common pediatric ailments, unfortunately. There are a variety of causes, most commonly viral invasion or viral infections like salmonella or rotavirus. Infants are unfortunately more susceptible to diarrhea. So how does it manifest itself? Of course, in an increased number of stools and increased fluid content of stool. How do we manage it? Well, we find the underlying cause. Is it related to a virus? Is it caused by a medication? We're going to then restore fluid and electrolyte imbalances as we find them. And then nursing interventions are INOs, promoting hydration, correction of electrolyte imbalances, and lab monitoring, making sure that what we're providing them for fluids is appropriate for their age, and then preventing the spread of diarrhea, and preventing complications. One of the biggest complications of diarrhea in kids are skin breakdown, okay? Especially if the child is dependent on wearing diapers. Skin complications are a secondary issue to diarrhea, so we're going to try to prevent those. Okay, opposite of diarrhea is, of course, constipation. So what is it? The passage of hardened stools may be associated with failure of complete evacuation of the colon. So this is when the colon doesn't empty as it should. How does it manifest itself? I feel like this is obvious, but hard stools, fresh blood in the stools if they're forcing stool to exit or bearing down, cramping, abdominal pain, anal fissures, pain with defecation, loss of appetite, and irritability are how it's going to present itself in kids. This is review, but the first stool again for babies should be within 24 to 36 hours. If there's not a stool within that period, this can indicate other illnesses or issues going on with brand new babies. How do we manage constipation? So typically with kids, we're going to add fluids, oral fluids. We're going to add bulk and fiber to their diets and increase fluid intake. So it's important to understand, though, that constipation, if it's not just a dietary issue, that there can actually be physical issues going on with anal stenosis, which would require manual dilation of that anal sphincter and administering laxatives and enemas, which seem counterintuitive, right? But if there's an anatomical obstruction, like an anal stenosis in a pediatric patient, then that's going to require us to make sure that the stools are loose and that they don't become obstructed. Until that can be dilated or repaired, we would want to make sure that we keep things loose and moving through. If it's as simple as constipation related to poor diet changes or dehydration, or not taking in enough fluid or fiber, then those are easier fixes with dietary interventions. Just keep in mind that if it's chronically going on, there could be an actual physical restriction. Okay, moving into GERD. So gastroesophageal reflux. So again, should be a reviewed concept. This is typically because of an incompetent lower esophageal sphincter. In kids, this is seen with chronic cough, wheezing, and pneumonia. So kids are spitting up or vomiting a lot. Aspiration may lead to respiratory signs, and esophageal ulceration and bleeding is when it becomes more severe. We diagnose this by health history, growth and weight patterns, upper endoscopy if indicated. Medical management for this is going to be small, frequent feedings that have been thickened with infant cereal if necessary, administration of antacids, so it's not uncommon for kids or babies to be on an antacid before meals and at bedtime. And then if it's related to a very incompetent esophageal sphincter, they may require a nissen or fundoplication, which is a surgical repair of that poor sphincter. And then nursing interventions for this are going to be teaching parents how to thicken formula or breast milk, how to identify if the child is aspirating, and then proper positioning after feedings, which is typically sit them up. So if right after a feeding or a meal or a bottle, that they should sit up for quite a while instead of just laying them flat on their back. Okay, we're going to move into what is hypertrophic pyloric stenosis. Okay, this is an obstructive disorder with where the gastric outlet is mechanically obstructed. I'm going to show you a picture here in the next slide. So this is a congenital anomaly of the pyloric muscle where it's gotten too large. The muscle has overgrown or hypertrophied so much that fluid or contents in the stomach can't pass into the small bowel. So the most common symptom of this is like projectile vomiting. Okay, so it affects boys more than it does girls. It manifests within the first 3 months. The exact cause is really not known, and the primary problem is the stomach cannot empty. Okay, so here's a photo. See on the top there, at the base of the stomach, fluids can pass into the duodenum, where in the bottom photo, it's hypertrophied and it's overgrown, and so there's almost a closure. Here's another picture. Okay, so how do we manage this? This is going to be with surgery. And then what do we do as nurses? Of course, any surgery like this, we're going to, or any complication, if they're not able to pass nutrition into their GI system or small bowel, then we're going to have to manage nutrition and INOs appropriately, whether that's preoperatively with IV therapies and TPN or after surgery, just maintaining proper INOs. Okay, so intussusception. So this is one of the most common causes of intestinal obstruction in children between ages 3 months to 6 years. This is a result of telescoping of the intestine. So that will make more sense when you see a photo in the next slide. This is twice as common in boys for some reason, and it manifests itself with severe, sudden onset of abdominal pain, vomiting, and lethargy, and this is important for you to know, current jelly stools, which is feces and blood plus intestinal mucosa look like jelly in the stool, okay? This is an unknown cause, but NCLEX trigger and test trigger is current jelly-like stools is related to intussusception. So this is a picture of that telescoping where the bowels really kind of slide back into it itself, essentially, and causes an obstruction. Here's another photo. Okay, so how do we manage this? Hydrostatic reduction or surgical treatment. So this is when they test, they'll push air or barium in an enema to try to forcefully exert pressure on the bowels to kind of cause it to not telescope on each other. So by pushing fluid forcefully in, they're trying to get it to unfold essentially. But if they're not able to, then they would have to go in and surgically remove that, either pull it apart, or if they're too late in the process and it causes bowel death, then they would have to remove that portion of the bowel and create an anastomosis. So nursing interventions for this are going to obtain history, observe physical signs, and then prepare the family for postoperative care. All right, Hirschsprung's disease, also known as megacolon. So this is an absence of innervation to a segment of the bowel where there's no peristaltic waves in the affected portion. This causes an intestinal obstruction and distension of the bowel. I'll show you in a slide coming up here. It manifests itself in abdominal distension, vomiting and poor feeding, ribbon-like and foul-smelling stools, essentially because the bowels are not evacuating appropriately. So as you can see in this photo, there's an enlarged portion of the bowels here where there's no peristaltic waves in this portion, which causes the defect to be enlarged, and stool essentially backs up in this area because it can't move through. So medical management for Hirschsprung's is almost always a temporary colostomy so that the bowel can regain tone. The bowel is known to be extremely irritable, so when we go in and surgically remove a portion of it and then create an ostomy, we need to let it rest. The gut needs to rest. So it manifests itself oftentimes with no meconium stool within the first few hours as a newborn. So if they don't have a meconium stool, and it's been 2 days, we're worried, and a lot of times it can correlate to this disease process. So nursing interventions are going to assist the parents with the adjustment to this type of diagnosis and essentially a colostomy, promote parent bonding and infant bonding, preparing them for surgery, and then educating them regarding colostomy care. So this is an animal in itself. Colostomy care is difficult with adults, and now add it to a little toddler who's running around and who probably is not going to really comply with wanting to keep it on. This can be difficult for parents that care for this. So another symptom typically is a weight loss. Kids that go through this disease process, one of the indicators can be a loss of up to 20 pounds. Let's see. So with colostomies, there's always the takedown. This is the second surgery where after the segment is that poor segment was removed and they have allowed the gut to rest, they take down the surgery where they create an anastomosis of that bowel and connect it so that it's back to its normal function and excretion process. Moving into hernias, this is also a GI issue for pediatric patients. What is a hernia? It's a protrusion of organs or portions of an organ through a structural defect or weakened muscle wall. Most common places are diaphragmatic hernias, hiatal, inguinal, or umbilical. Things that we are concerned about, I'll show you a picture of that next here, but things that we're worried about are strangulation and incarceration. So if the organs, specifically, typically the bowel, if they go through that hernia or that weakened wall muscle and they get stuck, it can cause bowel death. So in this next photo, you're going to see the locations for these. So umbilical, inguinal. So as you can see in those locations, you can have different organs protrude through those, but we're worried about them being able to be palpable. So depending on the severity of the protrusion or the size of the hernia is going to depend on treatment. So in my own experience, one of my children had an umbilical hernia, and all we did actually was we put a little Band-Aid externally over her belly button, which caused the protrusion of her intestines to not protrude through, right? So this isn't obvious that it's intestines necessarily, but she had a really large outie belly button for a long time. It probably lasted about 4 months before it closed on its own. And the abdominal wall eventually did close all the way where there's no longer a hernia there. It didn't require surgical, but it was just a constant checking to make sure that it was palpable and squishy and that it did not cause that it wasn't restricted or that it didn't close around the bowel. So the simple fix for this one was to pressure, right? We used a Band-Aid. The doctor did say we could put an abdominal binder on her as well, but a Band-Aid was much smaller and worked effectively. So that's just an example. Okay, moving into UTIs. So urinary tract infections, this should be review as well, but this is an infection that may affect the upper airway tract or the lower urinary tract, or can actually be both. So this is primarily caused by bacteria. Signs and symptoms are fever, weight loss, failure to thrive, feeding difficulties, vomiting, diarrhea, urinary frequency, pain during urination, foul smelling urine, incontinence, flank pain, and blood in the urine. Now, depending on the age of the child, those symptoms are going to vary, right? Because the younger they are, you're going to see more with feeding difficulties, failure to thrive, weight loss. And in an older child, like, 4, when they're able to describe, like, oh, it hurts when I pee, or pain during urination, incontinence when they were previously continent. Depending on the age, those symptoms are going to vary. So how do we prevent this? Proper cleaning of foreskin, and then teaching front to back wiping for females. And then treatment is antibiotics, of course. Okay, so nephrotic syndrome. What is it? This is damage to the kidneys that leads to the leakage of large amounts of proteins, mainly albumin, into the urine. This causes a range of symptoms. Okay, so the main features of this are high levels of protein in the urine, which often is detectable in urine tests. Low levels of albumin in the blood, or hypoalbuminemia. Edema, swelling in the face, abdomen, and legs due to fluid retention, which results from low albumin levels, and then hyperlipidemia, which is a compensation mechanism for protein loss. So clinically manifests itself with periorbital edema, abdominal distension, generalized edema, vomiting, anorexia, diarrhea, irritability, increased body weight, decreased urine output, and obvious edema, which you can see in this child here. Essentially, it's kidney or glomerular damage, which causes protein dumping in the urine, which causes a loss of protein in the blood. This decrease of protein in the blood decreases osmotic pressure in the capillaries, which causes the fluid to leak into the interstitial spaces, and this can happen in the face, in the body, in the extremities, and in boys or small babies can be seen in the scrotum, which is this next photo. Okay, so this photo is of a small child, and his scrotum is experiencing extreme edema here, which is obviously very painful. It's just sometimes it can be noted in strange places in kids, so in scrotal edema, periorbital edema, extremity edema, and so forth. How do we manage this? So they give prednisone, diuretics, adrenal corticosteroids, bed rest, low sodium diets. We're strictly monitoring INOs, body weights, and abdominal curve. We're providing skin care because with edema comes skin breakdown, unfortunately. We're monitoring their vital signs, and we're encouraging protein intake. We're instructing the parents to test the urine for protein dumping. They have to have good intake to offset the protein loss in the urine. So dietary modifications and restrictions, and then understanding the side effects of steroids that kids may experience. Most children affected by nephrosis outgrow this in their teenage years and don't have permanent kidney damage, thankfully. Okay, what is acute glomerular nephritis? Okay, this is an inflammation of the glomeruli in the kidney, commonly post-infection, specifically strep. So this leads to circulating congestion due to poor glomerular filtration rate. The kidneys are keeping too much sodium and water in the blood, essentially. So it manifests itself by sudden blood in the urine, protein dumping, increased thirst, urine may be cloudy, smoky, or tea-colored, and edema, abdominal pain, pallor, low-grade fever, anorexia, vomiting, and headache. How do we manage this? How do we manage acute kidney inflammation? Bed rest, restricted fluids, sodium and potassium and phosphate, regular measurement of vital signs, strict INO, antibiotic therapy if it's related to strep. And then we're going to promote rest and adequate nutrition. Prognosis is typically completely recoverable, even if treatment requires acute dialysis. So in severe cases, they may require dialysis, but kids recover from this well. It's important to understand that with acute glomerular nephritis, you would anticipate acute hypertension, which is why they use diuretics. Wilms tumor. So nephroblastoma. This is a malignant tumor on the kidneys, commonly on the left kidneys, and it affects both kidneys in less than 10%. So it's usually only one, and almost always the left, rarely both. So this peaks at ages 3 to 4. Again, a malignant tumor, so it manifests itself with enlarging asymptomatic but firm abdominal mass. And so because they're asymptomatic and it's in the peritoneal cavity, it takes quite a long time to recognize it. It has to get very large before it's noticeable and causes abdominal pain, blood in the urine, fever, hypertension, weight loss, and fatigue. So it has to get pretty large before it shows obvious symptoms. How do we manage this? So surgical resection as soon as possible. So as soon as we realize that they have a malignant tumor, of course they're going to want to remove it. Children with this disease are almost always on chemo from anywhere from 6 to 15 to 18 months. Unfortunately, this can be metastatic to the lungs, lymph nodes, and brain and bone. Exploratory laparotomy is how we're going to diagnose this. They're going to go in and remove it as much as they can, as long as it's not metastatic. This would require careful resection of the tumor. Nursing interventions and patient teaching. We're going to prepare the child and family for surgery, and then how to manage chemo and pediatric cancer, essentially. So there's a lot of guilt with this disease process because it's there for a long time and grows and can become metastatic before it's noted because of its location. So it's asymptomatic for a lot of its growth, and until it's progressed, is it noticed. And so parents have a lot of guilt with this, feeling like they should have found it sooner. Because a lot of times once they find the tumor, it's like a softball size, and so parents feel like they should have known it was there when really in reality they likely wouldn't have known it was there until there was symptoms. This can be frustrating for parents, in combination with battling the emotional trauma of now dealing with pediatric oncology. Okay, moving into structural defects of the genitourinary tract. So these have serious implications, of course, to psychological well-being of a child. This is what we're talking about is when a child is born, if their genitals are not fully formed, one way being either fully male or fully female. So prompt correction is necessary to avoid psychological impact of the child. Now that may be a charged topic in a world where gender assignment and or change is more common. This might be different than what the textbook suggests. Just keep that in mind. Nursing interventions and patient teaching are going to be preparing the family for making a decision. So unfortunately, this is a huge burden to bear for families because when genitalia is not formed fully one or the other, a lot of times they have to make a decision to assign gender. There's a box on page 1016, 32.3 that I would encourage you to look at. Okay, we're going to move into quickly here hypo and hyperthyroidism, and then a quick review of diabetes to close out the rest of this lecture. So hypothyroidism, there are two different types. Again, this topic should be reviewed based on MedSurg, but we're going to talk a little bit briefly about it. So there's two types, primary and acquired. So primary is a congenital defect or defective synthesis, okay? Acquired is an insufficient stimulation of the pituitary or the hypothalamus or systemic resistance to TH, the thyroid hormone. So congenital patients are going to present with cool and mottled skin, dyspnea, hypothermia, lethargy, poor appetite, poor suck, and prolonged jaundice. Acquired kids are going to present with constipation, dry skin, growth delays, lethargy, with the puffy eyes. This is one of those that are screened on that newborn screening at birth. So this is one of those federally recognized disease screening processes that we do to children where they do the heel stick and they're testing for endocrine disorders. So what we're looking for is hypothyroidism. Prompt initiation of medication is critical to prevent cognitive impairment. So it's super important with kids. If they have hypothyroidism, we really need to intervene quickly with medication and TH therapy so that we're not causing cognitive delays in kids. So assisting the child and family in compliance with medication regimen and then monitoring its side effects. So again, pediatric patients are very much at the mercy of their parents doing the medications correctly, especially when they're young. And so getting parent buy-in on the importance and compliance of monitoring and giving the medications as ordered is imperative. Okay, hyperthyroidism. So this is an autoimmune process resulting in the production of immunoglobulins that have TH stimulating properties. So the exact cause is unknown. They think it's autoimmune. It's very rare in young children, typically seen in Graves' disease or in conjunction with that diagnosis. Clinical manifestations are nervousness, irritability, hyperactive tremors, excessive appetite, weight loss, tachycardia, dyspnea, hypertension, accelerated growth, heat intolerance, and thyroid storms. There is the box 32.7, page 1017, that reviews hypothyroid symptoms. How do we manage this? Administration of antithyroid medications, or potentially even removing the thyroid, or iodine administration. There's some notes on page 1077 as well that would be beneficial that you review. Nursing interventions for this: promoting rest and providing a quiet, non-stimulating environment, dietary modifications including increased calories, preparing the child for surgery of that thyroidectomy, and then understanding one of the biggest complications to that surgery is post-op bleeding and suture line care right on their neck. So for kids, their necks, depending on their age, can be a really dirty spot. So it's important to review post-operative care with parents there on that surgery. Okay, so moving into diabetes. This should also very much be reviewed from MedSurg, but we're going to talk about it specific to PEDS just a little bit here. What is diabetes? This is a deficiency of insulin resulting in the alteration in protein, carbohydrates, and fat metabolism. So there's different types, right? There's type 1, which is where the body doesn't produce insulin. Type 2 is more of an insulin resistance, and then there's even types 3 and type 4 out there. You should look at them. They're pretty interesting. Diabetes is unfortunately more prevalent than it used to be in pediatric patients, especially type 2 diabetes, okay? So medical management for this is, of course, insulin replacement if they're type 1. Nutrition is always important regardless of the type of diabetes that they have, and then exercise. Nursing interventions are going to grossly center around family understanding of medication regimen, how to manage insulin if they're needing to give it, treatment and complications, how to identify hyper and hypoglycemia for kids, understanding that this is very much a lifelong treatment involving multidisciplinary care teams, pediatric, endocrinology, dietitians, primary care providers, daycare centers even, and school nurses play a role in managing diabetes for kids, especially if it's type 1. Okay. Prognosis of type 1 and even type 2 are highly dependent on compliance. So how do they manage their insulins and keeping their blood sugars managed, and preventing secondary issues related to mismanagement of diabetes? So I'm not going to review insulins and the types because, again, I think these should be reviewed for you. You should know the difference between rapid, long, short-acting, and intermediate insulins. Normally, if I was in class, I would write a chart for you to kind of break down the differences and types for these, but I would encourage you to create a chart, if you would, that breaks down the different types, right? Like Humalog, Lantus, Levemir, Humulin, Novolin. Where do these land as far as intermediate, short, rapid, or long-acting insulins? Because it's imperative that you understand. So as far as diabetes for pediatric populations, things that I want you to think about specific to kids, okay? So what are things that you might see as a pediatric nurse, or a nurse in a school setting, or specific things that I've seen in pediatric care as a nurse or a home care provider are insulin pumps. These are making it a lot easier to manage type 1 diabetes. School nurses work a lot with type 1 management, right, where the students are coming in before or after lunch to manage sliding scales, to take blood sugars before they eat, to program pumps based on carb correction. And then, that being said, type 2 diabetes is very much on the rise. I think that the textbook is a little bit outdated in the fact that it has not caught up to the issues with our American diets and food choices. So type 2 diabetes and childhood obesity is very much on the rise. So I would like you to think, how do we combat this? What do we discuss with parents? These are big needles that need moving in our food industry and our experiences of raising children, but food choices are imperative. We're in a fast-paced society where fast food is what's leaned on, unfortunately, a lot of times. And then even so, just like quick grab and go snacks. A lot of our foods that we're feeding kids on a regular basis are not healthy. So decreasing technology use, increasing activity and or outside time, and then encouraging parents to be healthy as a family is really going to help combat issues with type 2 diabetes. Okay, that was like the fastest review of endocrine dysfunction for diabetes, but I do very much believe that this has already been discussed greatly in MedSurg, so I just would like you to think specifically about those things related to kids. So how the buy-in and the education as a nurse is going to be imperative with the parents, and then as the child gets older, having them also understand the importance of managing what they eat, why it matters, and how they're going to correct with insulin safely. And then again, that it's a lifelong treatment, right? Type 1 diabetes, there is no cure. And so kids and families are going to need to buy in that this is a lifelong disease process, and that with mismanagement would be complications. So it would be in their best interest to manage correctly and help kids be successful with managing blood sugars, whether that be with insulin, diet, proper food and nutrition, and exercise. Okay, we're going to close out for part A of chapter 32. Thanks for sticking with me on this hour and 45-minute adventure.